it's saying general hold. I'm trying to think what's going on here.
We can't see you.
Can you now?
Yes.
Okay. All right. I don't know what link I'm in, quite frankly. I'm wondering if I'm in one of the teams or something, because it's saying general and then it says hold. Let me just hang that up. All right, that's better. Okay. All right. So you don't actually have to have those presentation care plans done until about 4 o'clock, okay? So I want to shelve that for a minute. But a couple of things that I want to go over with you. First of all, I do want to go over in chapter 11, which is one of the chapters that we're going to be talking about on Thursday. I want to go over some of the pieces that I feel are important. On page 169, or rather 166, 67, 69, it talks about the renin-angiotensin pathway. And what it's talking about, and this is relevant right now, I'm gonna have to mute some people. Let's see, who do I need to mute? I need to mute a couple of you. There you go. The reason it's relevant is because what it's talking about is the kidney's response to what is going on to perfusion. Because in order for the kidneys, in order for the body to perfuse, meaning in order for blood pressure to work, in order for the heart to pump and all of these things, the kidneys basically look at this and go, whoa, that blood pressure is dropping, that I'm not going to be able to do what I'm supposed to, the heart's not going to be able to do what it's supposed to do. And so it responds to that with what's called the renin-angiotensin system. And on page 166, I don't know if you guys have already looked at this a little bit in response to this case study, but it talks about what happens. Renin is released. And as a result of the kidneys releasing this hormone renin, it releases a couple of things. And one of them is angiotensin. And then that converts to angiotensin 2, okay? And then what that does is it constricts vessels. So basically it says there's not enough perfusion going on, it constricts the vessels, and so it allows the blood pressure to go up. That's what it does. What type of blood pressure medication have you heard about that would work in opposition to that? Any idea? You know it. I know you know it. An ACE inhibitor.
Okay.
All right. So when you see an ACE inhibitor, that is a angiotensin converting inhibitor. So it's preventing that vasoconstriction, isn't it? It's allowing for some vasodilation because you're trying to bring that blood pressure down. So I'm just trying to put it in context for you, okay? So what happens with this pathway is you've got constriction going on, and also the secondary thing that's going on is the kidneys are basically conserving sodium, because where sodium goes, water goes, right? So they're doing a couple of things as well. They're sort of saying, no, 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 we want more water in the body. We need that. And so it's actually stopping the sodium from being released in the body, and it's doing that piece as well. So I want you to just be aware of some of these little pieces of what the kidneys do in relationship with blood pressure. So when we're looking at things like this case study, and I know you guys did this morning you were doing the IV therapy, but I want you to be aware of when we're looking at these case studies, when we're looking at our patients, at some of the changes that occur with kidney function and dehydration and all of these pieces, right? So What are we looking for with these patients when there could be kidney function changes? Some really basic things. What might you see in a patient with kidney function that's going downhill?
Reduce urination.
Yeah, exactly. What are we looking for per hour with urine? What do you want at least?
60 ml.
30.
30.
At least 30 mLs an hour. Okay? Anything less than that is an issue. 60 is good. I want, you know, that's a good one. Thank you. But at minimum 30. All right? Now, what else could there be with the urine that you're looking at? Color, right? Yeah. If the urine is a really dark color, that could be a sign that there's an issue. It could be blood in there, right? Which could be an issue on many levels. It could be a kidney issue. There could be, you know, glomerular filtration issues, all those types of things. Smell, right? That could be an issue as well. So that's just some basic things that we as nurses, we're noticing and we're looking, all right? With our patients as well that might have kidney functions, what about things like their skin? What are you looking for with their skin?
Tinting of the
The
chin.
Yes, skin turgor, right? Has anybody ever seen old people and you do this to their skin, right? And it stays, it doesn't have that nice bounce back. It's called tenting, okay? That's something that you're going to be looking for. Another big change that happens with patients, and I've just been going through this with my father, and it's blowing my mind at the lack of nursing that's going on, and that I could talk about all of that for days. But when you've got an older patient in the hospital and they've got a baseline that's alert and orientated, and you see confusion with your patient, do you think maybe that might be a sign that there's some electrolyte imbalance or something going on?
Yes.
Yeah,
A lot of times if they have a urinary tract infection, that happens.
absolutely. Or it could be the beginnings of a UTI. You might not be seeing the UTI yet, but you're seeing some shifting of things going on. Okay, so these are the types of things that I just want you to be aware of when you're looking at your care plan. Let me see what's going on. This particular case is interesting, as I'm sure you've probably in your groups all started looking at, because she's getting a CT scan with IV contrast. Is that a big issue or not?
I'm not really. I don't think so. I mean, I'm not sure why they want the. I'm not really sure why they needed the IV for that. Is it just so they can see the flow?
Yeah, and it is a big issue. Evelyn, a lot of the time, IV contrast can, especially if you've got certain medications like metformin.
Okay.
If your patient is on metformin, and I'm not sure, it doesn't say with this lady.
It doesn't say.
Correct. But the problem is, metformin, you would think, is a fairly benign medication. Everybody's on metformin. Right? It's the first line med for diabetes. It's a great medicine, but not if you're doing IV contrast.
No.
You actually have to stop the metformin before and 2 days afterwards as well.
Right.
So these are the types of things that I am trying to help you think critically a little bit. And do you know why I want you to do that? Because then when I call up from another country and I'm talking to the nurses on the phone about my father's care, I'm not thinking, who is this complete imbecile on the phone who doesn't understand even the basics of nursing care? And believe me, I loved my training, but oh my Lord, I'm looking at some of this stuff that's been going on, and it's blowing my mind. And when I look at somebody who is, I'm using my father as an example, 82 years old, he was basically used to do Tour de France cycling, my father. So he was a Tour de France cyclist, has always been fit and healthy his whole life, and over the past 6 months developed a thing called bullous pemphigoid. It's a very, very, very rare skin condition, and look it up. It's really interesting. It's like Stephen Johnson syndrome on steroids, and you actually have to give steroids and everything else for it. It's been a cascade of events as a result, and he's now been in the hospital for the 4th time. Now, my father, who at 81 was still cycling and all the rest of it, can't even get out of bed now. He needs them to do a Hoyer lift to get him out. And in the past week, when I spoke to him on the phone, I tried to talk to him. I was like, that doesn't sound like my dad at all. It's weird that I could tell, but the nurses couldn't tell. And I called them and I said, you know, I'm not sure what's going on here, but my father, it just doesn't sound like him at all. He's saying some things that are not normal. And he knew who I was, but he just didn't sound right. Now, I know my dad, so I know the differences, right? I know those nuances. They don't. But even so, what was going on there? His H&H had dropped and plummeted. No one had noticed it. He needed 2 units of blood. Perfusion, right? He wasn't getting enough blood going on in his body. His blood pressure is so low that if he tried to stand up, he would fall down. Again, all of these perfusion issues are going on. His kidney function is worsening. Again, perfusion issues. So I'm just using my father as an example because we are advocates, right? That's what we do. And whether it's my father or your mother, I want to be that nurse who goes, hang on a minute. Mr. Smith didn't seem quite like that yesterday. There's those little gut instinct nuances that go on when you walk in a patient's room and you're like, I can't put my finger on what it is, but it's not what it was. And whatever that nurse told me from shift report, I don't know. Something's not right here, okay? I want you to have that gut instinct about you for your patients so that you're able to then go, let me go look at those labs. Or if they don't have labs, let me go and order some labs. Let me call the doc and say, you know, doc, can we order some labs here? There's something not quite right. And I'm bringing that up so that you can look at the sodium, you can look at the potassium, look at the H&H, and have a real good idea as a nurse that something isn't right and it needs fixing. Okay, what do you think about that? Just to get your feedback.
I don't know if you've looked at this particular case study that we're looking at.
Mm-hmm.
The sodium is at 132 on her.
Yeah.
Okay. So I'm trying to look for my book that has my numbers. I thought that it wasn't too bad, but let me just check if I looked at something wrong.
That's bad.
That's bad, right?
It's bad. Let me tell you.
That's why everything is.
What's a
sodium's off? Sodium is low because I have a normal of 135 to 145.
Good.
All
So
right.
you're recognizing that somebody said that is low.
Right. It's just a little bit low though.
No, it's not a little bit low.
Well, if it's 132 to 145.
135 to 145 is the recommended levels for sodium.
I understand that, but it's at 132.
That's low. That's
But
too low.
they're going to go crazy over 132?
I would not be happy if my patient had a sodium of 132. I would be quite concerned. Let me help you with that.
Okay.
Turn to page, and this is great. This is why I want to do this. All right. So let me help you with this a little bit. Okay, page 173 in your books. It's talking about sodium. All right. So look at on page 173, halfway down, it says hyponatremia, low sodium. Is anything actually below 136? Okay. So while that may not seem a big deal, remember, it's not just about the lab value. What are we looking at here? We're looking at a patient that is frail,
right?
That is thin, that has other issues going on.
Right.
She's got an acute abdomen with a bowel obstruction.
Correct.
Right? So we've got a lot of other issues going on. And yes, can we fix this sodium? Absolutely.
Yes.
But my concern is, turn on to page 174. And look at the at least 1, 2, 3, 4 issues just off the top of my head there, the issues with this patient having a low sodium. And 132, yeah, you know, that's a concern.
Then here's another question I have for you. Why wasn't she, when she was admitted, given IV fluids right away? Because it doesn't say in his orders to give her IV fluids.
So let me look at this for you. Hang on.
Because she was probably dehydrated from the beginning, because she's been having vomiting for 2 days. So
let me ask you this. One of the questions it says is, it basically asks, and it says, well, one of them is, which order would you question? I'm not talking about that right now, but it says, what additional nursing assessments need to be performed? Now, here's
signs of dehydration.
Right. So here's the thing. This is where your advocacy comes in.
Right.
Now, it's not a nursing, it doesn't say, would you order this? But within your assessment, you're assessing, yes, she's dehydrated, there's nausea and vomiting, all of those things going on. And then that's your cue to say, maybe we need to call the doctor, and for whatever reason, maybe she got admitted in the middle of the night and he or she was, I don't know, had 50 things going on and they forgot to order IV fluids. I don't know. All right. We're making it up. But for whatever reason, IV fluids were not ordered. Yeah. And so then we go, whoa, that's unusual. I think we better call, right? And see if they need IV fluids. That's our job. Yeah, that's our job.
Because it probably would have solved some of the other problems of her electrolytes being off like that.
Thank you. Because here's the issue that I've been running into for since March, since COVID hit. When I was supposed to fly out in May, and on and on and on. From the beginning, I'm going to use my father as an example. When all this stuff started happening, I would email the physician and say, hey, Dr. Mayo, Caroline from Florida here. Thank you for taking my email. And may I suggest this, that, blah, 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 right? And he's a wonderful doctor and actually listened to me. But here's the problem. It wouldn't be until I would make those suggestions that these things would happen. And I would suggest these things, and then because it's England, and I'm just going to go on a soapbox about that type of medicine for a minute, things don't happen quickly over there at all, at all. So the cascade of events occurs. So this is why I'm so passionate about us being advocates. And if I can do anything as a nurse and help to instill that, I will do that. That's my life goal. All right. So thank you, Evelyn. That's, you know, thank you for bringing this out. This is why we're discussing these things. So she is hyponatremic. It's not a good thing, right? So I'm not liking her creatinine either, this lady. I am not liking a lot of her labs at all. What do you think about that creatinine?
The creatinine is high.
It certainly is.
From 0.6 to 1.2.
Mm-hmm. Yep. She's definitely got kidney function issues there, right?
Yes.
Does anybody know what GFR means, by the way?
I can't remember now, and I should know this.
No, you don't have to. I'm just asking.
I worked in a lab as a phlebotomist. I should.
All right, well then yes, you should know this.
And I've been told this a million times. I would have to look it up because I can't remember.
Let me tell you. It's the glomerular filtration rate. All right, so remember your anatomy and physiology, right? With the glomerulus, with the kidney, the glomerulus is like this, right? That's the filtration piece of it, right? So we want that. The higher that is, the better that is in this case.
Well, so,
so again, a glomerular filtration rate of above 60 is what I like. When I start to see that dropping, it's the opposite to the creatinine. So all of these pieces, what's the body always trying to do? It's always trying to maintain what?
Hemostasis.
Yes, balance, yeah? That's what this fluid balance and this ABGs and now electrolytes and all of these pieces, we're constantly trying to maintain that fluid balance. And what do we use? We use different formats for it, right? Filtration. Filtration is more of a pushing, you know, it's pushing fluid from one environment to the other environment, right? You've got osmosis. What's osmosis doing? It's more of a pulling, right? Pulling the fluid from a lower concentration to a higher concentration in order to get that balance going on. Those are the pieces that I'm looking at there. And then there's diffusion as well, isn't there? Yeah, diffusion. And diffusion basically is the movement of the actual particles, right? And we're going to go over this a bit on Thursday, but I think it's really relevant. I wanted to truly tie these pieces in for you a little bit today, all right? So that's where we're looking at. And why is it all important when we're looking at where this particularly could go with her urine output, all right, and this particular patient? What are we looking at here? No urine output after 6 hours. I don't like that.
No.
It's not good. That's not good, right? She's going to get overloaded. She's going to get, what else is, what can happen to her mentation? What do I mean by mentation?
Did you say mutation?
Mentation.
A mental?
A mental status, yeah.
In confusion.
Yeah.
Absolutely. What can happen to little old people when they get confused?
Or
Thank you. So now this is really what I'm trying to do here. I'm trying to get you to put the pieces together. So this chick with a sodium of 132 and labs that really suck and a calcium that's 7.7. Remember, with the calcium, there's a very narrow window with calcium, very narrow. So all of these pieces add up to a cascading of events, right? That can quickly turn like that. Her K is going up. It's 5.5.
But this is all because she's dehydrated.
Big point, yeah.
Yes and no. Remember, the lady has a bowel obstruction as well.
But possible small bowel obstruction.
Possibly. True.
Yeah. So, I mean, it's, to me, the way this is written, it's possible they're not exactly sure what's going on with that bowel.
True.
So that's why all these numbers and all these problems she's having is because of dehydration, probably.
Partially. I think there's more to it, but we'll go with what you're saying for this section.
But that's what's bringing down her oxygen level because of the fluid.
Hold on. Another thing too is I don't think you paid attention to is when it says they did the head to toe inspection and it revealed crackles in her lungs, right? So that was probably another reason why they didn't want to force all that fluids, because if she has a lot going on, they need to remove the fluid from the lungs. So they need to give her a diuretic. So that's why they wouldn't originally go ahead and push the IV fluids. They have to balance the situation out, and that's not pushing her with IV fluids and at the same time you're trying to drain her lungs of fluids is not a good look.
So here's one of the things I do want you to bear in mind is one of the words that I keep saying to you is perfusion. Okay, it's not all about dehydration. It is about other pieces as well. Remember what I said to you about the renin-angiotensin system. Okay, if the kidneys, if your body is not perfused properly, your kidneys are going to start compensating in certain ways. Now, let me just tack on a little bit more. She actually does have a bowel obstruction. It resolved by itself. Great, thank God. She didn't need to go to surgery. That's a good thing. But she does have a bowel obstruction. So we have to take all of those pieces into consideration because I, thank God, have never had a bowel obstruction, but my husband has. Fairly recently, in fact, he had a bowel resection done. It's 2020 has been a great year, stellar year. And, you know, he's one of these incredibly happy people. I have never seen my husband, I don't think I've ever, he's just that type of person. He's really happy. Bowel obstructions are incredibly painful for people. So you're adding in pain with this patient, which she has. All of those pieces. What did we talk about this week about pain, or rather last week? We talked about the neurotransmitters and the effect of pain, right, on the body. Has a lot of effect on the body when we have pain on a physiological level. So all of these pieces dovetail together to create a cascading of events. Yeah. And Mimi, thank you for that regarding the crackles in her lungs. Absolutely.
Yes, ma'am. Thank you.
We've got that issue of what the heck are we going to do? Yes, we need to give her fluids. No, we don't want to give her too much fluids and overload her completely and send her into heart failure, right? Or anything like that. So again, it's all a balancing act. And sometimes it's a case of, you know, what fluid are we going to give? Are we going to give just normal saline? Are we going to give half normal saline? Are we going to give a hypotonic solution, an isotonic, which is your normal saline, or a hypertonic type of solution? It gets more sodium in it, right? So again, we have to look at all these pieces. It's never, ever just simple. Never. It's never simple. All right. So anyway, I'll let you guys continue working on this. Great. And this is great conversation. I appreciate this. I wanted to I wanted to touch base with you about a couple of things. First of all, know your lab values. Know your electrolyte values, all right? Start to really dig in and learn them. But one of the things I want you to bear in mind, and this ties in with the quiz for Thursday, is on page 177. And it talks about hypokalemia. What's hypokalemia, first of all?
Decrease, oh God.
You know,
Potassium.
yeah, there you go. It's low potassium, right? So when we have a patient with low potassium, of course, there can be the issues that we've already sort of, we can look at the fact that it can be a life-threatening event. Too much potassium or too low potassium, life-threatening. Usually, when I think potassium, I think cardiovascular changes, EKG changes. You know, that's where I'm going when I'm looking at hypo or hyperkalemia. What I want you to be aware of on this particular page on 177 is what you're going to do with your potassium. Would you ever give potassium IV push?
No, ma'am.
I want to hear that from everybody.
No.
Good. Good. And remember that there is an infusion rate, okay? The infusion rate is usually 5 to 10 millimoles per hour. So let me ask you, if you are giving 20 millimoles potassium in a bag of just say 250, how many hours are you going to give that over? I'm just
Like, I think it's 24.
Well, just remember I said your infusion rate is 5 to 10. So you can give, 10 MEQs or 10 millimoles per hour. You can give 10 MEQs per hour. So if you've got an order for potassium of 20 MEQs, you know, you could give that over 2 hours.
2 hours.
But I always err on the side of caution, and usually I'm doing a potassium over about 4 hours. You know, 40 MEQs, it would probably go over 4 hours. 20 MEQs, depending on the patient's, depending on the patient. But, you know, you're never going to do more than 20 MEQs per hour, ever. So at the bottom of page 177, it just shows you the drug alert. And there is a question on the quiz related to a mils per hour question. Now, it's not going to be a trick question, but it is to do with potassium. And so I did want to bring this point out, okay? The focus is going to just be on mils per hour. But I want you to be aware of this because it's a huge issue. I mean, you could kill someone very easily by giving too much potassium too rapidly. Okay. So, you know, and the other thing, of course, with potassium does what to the IV? Anybody ever had potassium in an IV?
It burns.
It burns.
It burns.
Right. When you know it's burning, you know that it's probably being given too fast.
Too fast.
Mm-hmm.
You may need to slow that drip down. Okay? When my patient says something burns, you listen. Really? Okay. I don't care, you know, if it says I can give it at 20 MEQ per hour.
Mm-hmm.
Slow it down. All right. If you have to do it at 5 MEQs per hour, okay. I'm not built the same as somebody else. You're not built the same as somebody else, right? You hear what the patient says and you adjust accordingly. That's what we do. That's good nursing, right? So anyway, these are just some of the little pieces that I wanted to bring out. I'm actually looking forward to going over some of these things as well. Now, let's see, it's 1:45. I'm trying to think. Do you want to go over a bit of ABG work, or do you want to finish your care plan and then do ABG work?
Since the care plan is due at 4, I would like to finish the care plan, if that's okay with
Yeah.
everybody.
Finish your care plan?
Let's just get this done.
Okay. What does the other team feel? You guys are very quiet.
It doesn't matter.
Well, I'm gonna go with the flow. I'm not gonna push any buttons.
Okay. All right, let's get together at 4 and we'll go through all of these pieces. And Evelyn, I like your idea tomorrow of basically getting your thoughts together, getting your stuffed toy or however you want to do it. And it better be a stuffed toy with an arm, I hope. I mean, you know. Although I'm going to tell you a story, and this is recorded as well. So I work with a very amazing physician. She's very visionary, very, and I like her because of that. So they were trying to get an IV. This is outpatient, and she works in a very close community of people. And I'm prefacing all of this. So this particular person needed an IV, and for whatever reason, the phlebotomist couldn't get his arms. They tried and they couldn't get it. And Dr. Quinn is a surgeon, and this is the physician I work with. Maybe I should not be recording this. So she managed to get an IV where you would never ever do this, and neither would I. But she did. You know, the penile shaft has a huge vein in it, and that's where she got. That's where she managed to get this particular medication that needed to go in this patient. Yeah.
You do what you gotta do.
You gotta do what you gotta do sometimes. And the patient was like, oh my gosh. But you know, you gotta do what you gotta do sometimes. So anyway, on that note, I will let you get on with it. And let's see, we will get together at 4. We'll see what we've been doing. And I would, as I say, I'd just like to do a little bit of ABG, and I'd like to go over the quiz a bit with you for Thursday so that you can start prepping as well for that. Sound like a plan?
Okay, can Rhonda and you, Miss Professor, and Mimi, can we stay online and talk this through, please, real quick?
Yes, absolutely.
Can you check your remind, Professor?
Oh.
And then we can get this done.
Okay. I don't know what that means.
Okay.
All right.
All right. Rhonda, are you there?
Elisa, you might want to join your colleagues. Hey, Rhonda, are you there?
Yeah, I'm here.
Okay.
So how do we want to do this now? Honestly, I was just trying to be helpful with this nursing care plan. I just wanted to get something on paper, and then we could go off from that. So how do we want to handle this the rest of the way?
So what do you have? What have you done already, Evelyn?
Pretty much the whole thing off of the sheet of paper that you gave us.
The good. Oh, see, good. So you used that one. Okay.
I used it all the way through.
Okay.
And I only did it just to start something, and then we could base it off of. That's all. So we weren't underneath the gun.
Perfect.
So,
So-
and if you don't want to use it, that's fine. We can start all over again. And that's okay with me too. It just was ideas on paper.
So you've got the care plan, but Rhonda might have some other pieces to add to it. You all have the same.
No, I
you'll
know I
add
don't
it,
got no other
presume?
pieces I want to add to it. Let's just send it just the way it is and run it just the way it is.
Evelyn, I got some tweaks, but that's only because, like I said, the when I found about the crackles and the stuff like that, or whatever.
Yeah.
So just a couple of little
Okay.
tweaks.
That needs adding in. And what, Rhonda, I think it would be good to have some input of the things that you are thinking about as well. It needs to, like we just discussed, when it comes to patients, and this is another reason why I have learned over the years, and believe me, I'm a lone wolf. When I used to have to do teamwork, when I was doing my BSN and my masters, I would dread it. But by the same token, I always learned something from the people that I worked with. And I've learned over the years that I don't know everything.
Miss Fletcher, I just want to be done and over with. Like I said, I don't have no problem working in a group per se, because my other terms and the previous terms I worked in group pretty well. But like I said, I don't want to have to be, belittled and downgraded because of what input I do put in. Like, it's not good enough. So it's best for me to keep my mouth closed and let people just do their work and submit their assignment and move on. That's it.
That's
right.
I was not Rhonda, I don't know why you feel that way at all. I'm open to everything. I mean, when we talked about the questions and stuff that, I had done the questions, you had done the questions. You brought up a great point with the medicine, and I didn't see that. I went a different way, and you were absolutely right. So I was redoing it to have what you said. So, I mean, I'm trying here.
Yeah. So I would suggest, Rhonda.
You know what? Just send it over, because I don't like nobody doing shows and trying to, make it more than what it is. Just run that assignment just the way it is.
Well, no, they need your input too. It's what I can't remember where you work, Rhonda. I know that you do.
Professor Fletcher,
Yeah.
I am 53 years old. I'm not doing this. I'm turning in this work just the way it is. I'm getting off this call.
Miss Fletcher, like I said, she trying to make it about her. It's not about you now. No, you want to argue with me because you and your friend done got together. That's fine.
Oh my God.
All right, ladies.
So,
that's not
remember,
true, Rhonda.
All right.
You and I were working great together.
Yeah.
I didn't see there was a problem.
I think that this day is not a great day. I think it's good to take a breath. And ultimately, this has been a learning experience. And if you want to, here's where I'd rather go with this. I'd rather focus on the positive and, like I said earlier, use the energy to look at this case, put it together, present well, and learn, then deal with this. Because this is time wasting. So we are going to just, if you want, Rhonda, you've been heard. We'll roll with what we've got. We'll go with it. And we're just going to move on. All right?
No disrespect, Professor. I can talk to Evelyn offline, and like I said, with the crackles and everything else, I would just like to add a few things with my 14-year nursing experience.
Yes.
I just like to add a few things to it.
Yes, I think that's the whole point, that you come together and go, well, I noticed this, I noticed that, I noticed the other, and then it comes together.
But that's how I thought. I just was trying to give us an outline.
Evelyn did
that's
great.
all.
Evelyn
I'm
did
going to
great.
let you guys finish it up. We're going to get back together at 4.
I need, girls, I need 5 minutes to
Take
pass up.
your time.
But we're meeting at, Evelyn, because I don't want, what I'm not going to do is be belittled on phone and threatened. So I need where are we meeting at?
Wherever you want. You can call me. It's fine.
Okay.
Either call or use the Teams channel.
Yeah.
But
I mean, I don't think Rhonda wants to be.
Rhonda
part
doesn't
of
want to be
it.
called. Right.
Okay, so then you and I will talk on the phone. Just give me 5 minutes, okay?
Yes, ma'am. All right.
All right, thank you.
You're welcome.
okay, guys, I'm going to get off the call and I'm going to let you all figure it out. And I'll be back with you all at 4, okay?
Bye, Professor.
All right, thank you.